Dialogue with a Doctor, featuring Southwest Florida's leading physicians.
Welcome to Dialogue with a Doctor. My name is Dr. Greg Leach, and this is a show where we interview local experts in their field. Today we have Dr. Raymond Phillips. He's a practicing gastroenterologist, board-certified gastroenterologist in Naples, Florida, and has a group of physicians here. You started the practice, so I'd like you to tell us about yourself before we get on to talk about colon cancer again.
Well, absolutely. I'm a board-certified gastroenterologist. I went to college, Princeton, graduated there after 4 years, an Army ROTC scholarship, went to medical school, Washington University, graduated there after 4 years, did my internal medicine training at Jefferson Hospital in Philadelphia after 3 years, and then I was chief resident for a 4th year. Then I went on active duty at that point as an internist at Fort Leonard Wood, Missouri for 2 years, and then I was selected for gastroenterology training at Walter Reed for 2 years, and then I was on staff at Walter Reed for 2 years where I did research and supervised the training of fellows and care for patients. After that, I left the Army after completing my obligation and came down to Naples, and I've been in private practice here in Naples. Our main office is in downtown Naples in Colonial Square, and we have offices in Marco Island as well as Bonita. We're working with Dr. Libersky, Michael Marks, Dr. Rivera, as well as Urbina and Dr. Hara. So we have a growing practice and specialize in gastroenterologists who, as I just said, I have a great deal of training, anywhere from 12 to 15 years of training, but are experts in digestive ailments and liver disease and nutrition. And so, there's a broad range of areas that we have expertise in.
Well, we're going to start out by just using some questions from patients, our audience, about colon cancer screening. And one question is, what is meant by screening for colon cancer?
Well, screening is a circumstance where you're trying to detect colon cancer at an early stage, at a stage before you might necessarily have any symptoms. As we were talking previously, if by the time you have symptoms that make it apparent to you that you have problems such as bleeding or irregularity, change in bowel habits, if you do have a colon cancer as the explanation, the problem is so far advanced that we no longer can necessarily intervene in an effective way to cure you. So we've gotten away from relying on symptoms exclusively and now have encouraged people to have some type of screening. And screening in its definition means trying to detect a colon cancer at an early stage before it's evolved and begun to spread elsewhere outside of the colon. So there's different ways to screen for folks, but that's the definition of screening. Mm-hmm. Which is, you got me excited on this now, and that which is a different topic from prevention of colon cancer. As we were saying before, we can actually prevent colon cancer because now we understand the sequence of polyps involving to a cancer. If we can detect a polyp and remove it, we can prevent it from maturing into cancer, which is a way of actually of not allowing that cancer cell to ever take hold in the first place. So it's a different concept, and sometimes people get a little bit blurred about what we're trying to achieve.
So we don't want really to detect a cancer. We want to screen so you prevent it from actually happening.
And that's where we've had the greatest success, is that, and that's not to say we don't want people to have screening for colon cancer. It's worthwhile, but what we're learning is if we can prevent it from ever developing in the first place, we can be much, much more effective. And we believe, and this is in response to a question you had on an earlier show, in terms of how much colon cancer could we prevent, we believe we could prevent upwards of 60 to 70% of all colon cancer in the United States if we had all the people who should go out and have an examination done undergo some type of examination, in particular a colonoscopy in this circumstance. So we believe we could prevent about that number of colon cancer. The troublesome thing is that is that one, people are a little bit shy about having these kind of examinations done in terms of a colonoscopy in particular. And then it's important when you do a colonoscopy that you go see a gastroenterologist or board certified gastroenterologist who's good at doing these examinations. We've talked in other shows about how it's important with quality indicators to ask your gastroenterologist how good are they at finding polyps.
I think I remember you talking at one time about there's a standard in terms of it should take a certain amount of time to do a colonoscopy.
Absolutely, and we've developed different standards, and it's and intuitively they make sense when you consider them. If you do a thorough, careful inspection of the colon, that means you've spent more time doing it, and you'll get a better result. And we've learned that if an individual, a gastroenterologist, spends more time, they get a better result. And there's certain thresholds in terms of time that have been used. But a more powerful indicator, that is to say, how good are you at finding polyps? We now have of levels at which we believe any gastroenterologist should be able to detect in individuals who might have a polyp. For example, if you take 100 men or women who are age 50 to 60 who are presenting for their first colon examination, never had a polyp before, and they're presenting for their very first examination, there's a certain prevalence of colon polyps that should be present among men as well as women. And so currently it's felt that you should have a detection rate of at least 25% in individuals who present for screening. So polyps are pretty common across the United States, and if your gastroenterologist doesn't have at least a 25% detection rate, he's not very good. And so that's a useful way or question to pose to your doctor as far as how good are they at doing this examination. What's your detection rate?
And the prep has to be good.
And the prep has to be very good because it's a team approach. In order for us to do an effective preventative examination of colonoscopy, there has to be a good preparation. And that means this laxative preparation that's taken the day before has to be really followed to the letter as far as doing it effectively. And your gastroenterologist really should coach you on that in terms of making sure that you do a good job. And then with that adequate preparation and an effective gastroenterologist, we can be much more effective in terms of prevention.
Now that we're talking about colonoscopy, I mean, do you still do sigmoidoscopies? Do you still do barium enemas? These other techniques that used to be used?
Yeah, some of these techniques have fallen out of favor or not used that extensively any longer. For example, this method called barium enema, where barium was put into the colon, or lower GI series was the other name for it. Really, that's a radiology procedure, and the radiologists have stopped doing that in the last 10 years. So most radiologists don't have any expertise any longer in doing that. A sigmoidoscopy is an examination of the lower third of the colon rather than the entire extent of the colon. And just for your audience, whimsical facts, the colon's about 4 feet long in men, about 5 feet long in women. And a sigmoidoscopy was done as part of the physical and was encouraged as part of the physical in the mid-1900s because most colon polyps and colon cancers occurred in the lower third of the colon. But over the last half of the 20th century, polyps and colon cancers became evenly distributed throughout the entire extent of the colon. So now it was learned that, hey, if you're going to really detect polyps, you need to look at the entire extent of the colon and not just the lower third. So sigmoidoscopies fell out of favor as part of doing a physical examination.
Well, I've had patients questions still to this day about not wanting to have a colonoscopy, worried about how it's done, which is really not a problem, to have it done, but still it's a conceptual issue, and wanting to instead have a radiological procedure like a CAT scan of some kind. Is that still done?
Well, the other name for it's called a virtual colonoscopy. And it's actually quite an innovation in technology where using CT scan or CAT scan technology that creates a two-dimensional cross-section of the abdomen, like you're sliced up like a bologna, and then using computer processing, you're able to reconstruct these two-dimensional images of the abdomen into a three-dimensional image and actually get an image as if you're inside of the colon itself. So the virtual colonoscopy is the name of it, and it's effective for finding small polyps. The troublesome thing is so effective for finding small polyps or residual material that oftentimes, we're having a lot of false positives in terms of people being told they have polyps and they really don't. And as a result, many individuals with virtual colonoscopies are now having to undergo a colonoscopy with an additional preparation. So, and for that reason, virtual colonoscopy has not become widespread and has not been really embraced as far as across the United States. There's certain parts of the United States where it's done in Wisconsin and so forth, but it's just because that's where the developer of the technology came from, and it's used a great deal in Wisconsin.
Even if you found one,
then you'd have to have a conventional colonoscopy.
You'd have to have it.
And so, but the virtual colonoscopy has a role for those individuals just unwilling to have a conventional colonoscopy, or who are unable because of either, sometimes you can have scar tissue or narrowing of the colon that prevents a complete examination of the colon, and then a virtual colonoscopy has a role then. So yeah, those are some of the different methods: sigmoidoscopy, barium virtual colonoscopy. But far and away, the colonoscopy, screening colonoscopy, the conventional one, has become the most widely used means of prevention and screening. Now, there have been some newer innovations, though, and newer innovations are variations of a theme. We talked about testing for hidden blood, occult blood testing, and there was a variation of that where you can detect human blood exclusively, and not blood that's been ingested, say, from like a rare state, which is from has another kind of blood type. But there's newer molecular biology techniques where you can actually detect the abnormal DNA from developing cancer cells within the colon that remain intact within the stool, and can be using various polymerase chain reaction techniques. You can be able to detect these abnormal DNA and actually determine with a very high degree of accuracy whether someone has a developing colon cancer. Now that's a tool for detection of colon cancer, screening for colon cancer, but not for prevention. But it's useful because it's a non-invasive technique where an individual will just submit a specimen.
Is that commonly used, the immunochemical test?
Well, the immunochemical test, called a FIT test, is widely used by many internists. This other technique that I just described, abnormal DNA, it's called a Cologuard test. That's increasingly being used. And essentially, it's a lot easier for patients. You just submit a specimen, a stool specimen, mailed away, and then you get a result a week later. So it's quite an innovation. The notion is, with these different techniques that are being available, for whatever reason, some people are just not going to have a screening colonoscopy. And rather than saying it's, hey, if you don't have that, we're not going to do anything, finding some method to screen individuals provide us the best opportunity to really reduce colon cancer deaths and to actually be able to succeed in terms of reducing the incidence of colon cancer.
Should those be done yearly, these non-invasive tests?
Well, the answer is, for testing for hidden blood, that's done yearly. For testing for abnormal DNA, called that Cologuard test, that's every 3 years. Okay. For a colonoscopy, a screening colonoscopy, because now that we understand how slowly polyps evolve, if you do not have a polyp and there's no family history, then every 10 years is adequate. If you have polyps and it's clear that you have a tendency to form them, then we'd want to come back in 5 years' time. Now that might be modified to a shorter interval if you have a lot of polyps, or if you have large polyps, or if there's a particularly strong family history. We might even make it 3 years. But the notion here is not only doing an effective examination with good preparation, with an effective gastroenterologist who's good at what they do, but also paying attention to the interval of these examinations. Because, you know, doing more frequent examinations, for example, before we understood the time course of colon polyps and evolution into a colon cancer, we used to tell people to come back every few years. But doubling the number of examinations doubles the risk, but doesn't improve the outcome. So it's worthwhile to pay attention to intervals. So I know we're beyond our time. I appreciate the opportunity to come here, Greg. It's always good to talk with you about these different subjects and have an opportunity to talk in more in depth about some of these subjects.
Thank you, Dr. Phillips. I still learn something every time you talk, so we really appreciate you coming.
All right.
And we want our audience to come back and hear more from Dr. Phillips in the future. Thank you for being with us.
Thanks, Greg.